Chapter 2, First Aid for Criminal Justice Officers of the High Liability book. The EMS system is a network of trained professionals linked to provide advanced, out-of-hospital care for victims of sudden traumatic injury or illness. Know that a trauma is any injury. Know that EMTs stands for Emergency Medical Technicians. Your first aid duties will include maintain an open airway, assess patients, perform cardiopulmonary resuscitation, aka CPR, control bleeding, which is exsanguination, stabilize injuries to the spine and extremities or limbs, care for medical and trauma emergencies, and assist other EMS providers. Keep in mind that you are prohibited from administering any type of medication to a patient. And then obviously Narcan is the only medication that you can give. But you're prohibited from administering any type of medication to a patient. I guess Narcan isn't really considered under that. Your first priority is to protect your safety, the safety of the patient, and the safety of bystanders. There are a list of things to do here. There's 1, 2, 3, 6, 7, 8, 9, 10, 11, 12. So the first one, wear personal protective equipment and stay aware of your surroundings, so PPE. Gain access to the patient, so triage. Assess XABCs. Determine whether the emergency is life-threatening. XABCs are exsanguination, airway, breathing, and circulation. Problems: exsanguination is a life-threatening bleeding or severe loss of blood that could lead to death. Then your next step is to stay calm and communicate. Keep your appearance neat, clean, and professional. Maintain a caring attitude and let them know that more help is on the way. Make sure to alert EMS. Provide the patient with care. Make sure to assist EMS. Keep your skills current. Keep records and collect data of the situation and work with other public safety personnel. What makes your role so vital is that you're responsible for the patient in the first few minutes after the trauma. We move on to Lesson 2, Legal and Ethical Issues. The public experts and the law requires you to be competent with behavior that is always above reproach. Protect them, their families, and their confidentiality while providing appropriate care. Placing the public's well-being first during an emergency reduces the likelihood of acting unethically. So putting the public's well-being first reduces the likelihood of acting unethically. Then we go into duty of act. Duty to act is a duty to take some action to prevent harm to another and for the failure of which one may be liable, depending on the relationship of the parties and the circumstances. If you are a correctional officer or correctional probation officer, you have an obligation to provide care to a patient who needs and consents to care only while you are on duty. If you are a law enforcement officer, you have a duty to act 24/7 within your jurisdictional boundaries. You also have the duty to render first aid following use of force when you know or it is evident that the person detained or in custody is injured or requires medical attention. So again, law enforcement officer, 24/7 duty to act as long as you're within your jurisdiction. And obviously correctional and probation only when you're on duty. Then you have breach of duty. This occurs when you either fail to act or act inappropriately. Then you have standard or scope of care. Standard or scope of care is defined as the degree of care that a reasonable person would exercise. Then we have the Good Samaritan Act. This protects a first aid provider from liability for medical care performed in good faith or medical care similar to that expected of another first aid provider with equal training. Medical care includes using an automated external defibrillator, which is an AED, as provided for in the Florida statutes. Abandonment is giving up a right or interest with the intention of never again claiming it. Make sure to continue providing emergency first aid until another medical professional with the same or higher level training replaces you or you are unable to continue. Negligence is the failure to exercise a standard of care that a reasonable, prudent person would have exercised in a similar situation. Any conduct that falls below the legal standard established to protect others against reasonable risk or harm, except for conduct that is intentionally, wantfully, or willfully disregarded of others' rights. So let's look at that real quick. Duty to act means you obviously have a duty to act and help somebody. The breach of duty is obviously the breach of duty to act. Standard or scope of care is the degree of care that a reasonable person, so it's just reasonableness. Good Samaritan Act is good faith, that a normal person with equal training would do the same thing. Abandonment is obviously leaving without the intention of coming back. And negligence is failure to exercise the standard of care. So remember, negligence is failure to exercise standard of care, where standard of care is degree of care that a reasonable person would exercise. Negligence occurs in all these conditions if all these conditions are present. So you have your duty act, breach of the standard of care, causation, which is your action or inaction, actually caused the patient injury, and then damages, the patient was harmed as a result of your actions. That having those 4 elements makes negligence. Then we have battery. When you provide emergency first aid without the patient's consent, you may face a battery charge if you touch a patient's body or clothes. Then when it comes to consent, for consent to be valid, the patient must be competent and the consent informed. So two things that have valid consent. They must be competent and the consent must be informed. A competent adult is one who can make an informed decision about medical care. Consider an adult incompetent if they are under the influence of alcohol or drugs and meet the criteria for the Marshman Act. An incompetent adult can be in an altered mental state and meet the criteria of the Baker Act. Consider an adult incompetent if they are seriously ill, have an injury that affects judgment, or are mentally ill, or have a developmental disability. To obtain consent from an adult, begin by identifying yourself. Then we have our 3 types of consent: implied consent, express consent, and informed consent. So implied consent would be the patient rolling up their sleeve when you're about to administer something. Express consent would be clear or written. And then informed consent would be like an information packet that you fill out at the doctor's office that has 10 pages of information for you to read. So again, expressed is clear or written. So like verbal or nonverbal in the sense of nodding your head yes, saying yes, asserting to or agreeing to the medical care, where implied consent would be if they're unresponsive or if they're like offering their hand to you or do some action that shows that they're willing. You must have a parent or legal guardian's permission before providing care for minors that are under the age of 18. An emancipated minor is someone who is financially independent or does not live with a parent or caregiver, is married, or is an active member of the military. Make sure to call the abuse hotline if there is a situation of abuse. And then we have our do not resuscitate / advanced directive orders. A do not resuscitate order is a DNR, or an advanced directive is legally binding in Florida according to Florida statutes. The DNR documents the terminally or chronically ill patient's wish to refuse resuscitation. An advanced directive documents the patient's request to withhold specific medical care. Criminal justice first aid responders do not have authorization to honor a DNR or an advanced directive. You cannot withhold resuscitation or first aid. So basically, it doesn't matter if they have a DNR or an advanced directive, you are providing care until someone relieves you. So again, a do not resuscitate means they don't want CPR. An advanced directive documents the patient's request to withhold a specific type of medical care. Then we have a medical alert. This is usually a bracelet, necklace, or card, and is known as a medical alert. HIPAA, well, also note with organ donors, remember their patients first and their organ donors last. HIPAA, a patient's privacy, medical history, condition, and emergency first aid is by law confidential information. The Health Insurance Portability and Accountability Act of 1996 is HIPAA. Again, that's Health Insurance Portability and Accountability Act, and it protects the rights of patients and the release of patient information. And note, when it comes to DNRs, that a tattoo of a DNR does not count either. They have to be written and signed. Know that every scene is a potential crime scene. As always, your first concern is your personal safety. Then we move on to Lesson 3, Professionalism and Communication. Remember that all patients deserve equitable care. Good listening skills display caring attitude and are part of good communication. When dealing with an emotional patient, family member, or bystander, redirect the conversation to divert their attention. So if they're super emotional and stuff's going on, maybe give them a task, right? Go say, hey, go grab me this, start wrapping this. Give them something to do to take their mind off of it. Remember that your main goal is to treat the medical emergency the patient is experiencing. Family members and bystanders are secondary concerns. Empathy is one of the most helpful tools to use in a crisis situation. Then we have patients with special considerations such as visual impairments and blindness, clues including eyeglasses, a collapsible white cane with a red tip, or a guide dog, and if possible, keep the patient and the dog together. Then you have hearing impairments and deafness. A person who has been deaf for some time will probably indicate the condition to you by pointing to their ear and shaking their head. One technique is to look directly at the patient, touch a place on your body, and make a face that indicates pain. Then you would have older patients. Note that they can have feelings of embarrassment by their physical appearance or condition. Then you have chronically ill patients. Make sure to ask the patient or caregiver how special equipment works as you provide emergency first aid. And then you have patients who speak another language. Hand gestures can be the best way to communicate with the patient if no interpreter is available. Then you have the developmentally disabled. Communicating with developmentally disabled patients can be a challenge. If available, designate a single person to communicate with the patient. Speak in short sentences and use simple words. Repeat or rephrase your statements until the patient understands. Remember that you may easily confuse or cause fear in a patient, and you may need extra time to reassure a developmentally disabled patient. Then the last form of patients with special considerations would be infants and children. Children are sensitive and can respond negatively to what they observe and feel. Avoid removing a child from parents when you do not suspect abuse. Be aware of asking medical or legal questions and jurisdictional limitations regarding questioning children who are victims of crimes. The Florida statutes require each judicial circuit to set limits on the number of times law enforcement officers may question juveniles. Make sure you are familiar with your circuit's limits. Then we move on to Unit 1, Lesson 4, Health Issues. We're going to start with stress. Learn to identify the warning signs of stress, which are inability to concentrate, difficulty sleeping and nightmares, anxiety, inability to make decisions, guilt, changes in appetite, changes in personal relationships, isolation, changes in work or recreational habits. Then we have lifestyle choices. Nutrition. A healthy, well-balanced diet and regular meals can help prevent and reduce stress. Then we have exercise. Exercise is a great stress reliever. And relaxation. Relaxation takes many forms, such as meditation, religion, sports, hobbies, or other activities. Then you have on-scene stress relief, such as breathing, taking long, several deep breaths, and thought patterns. Consciously change your thought patterns and remind yourself that you are essential, you are in control. Then we have death and dying situations. There are 5 stages of this. You have denial, anger, bargaining, depression, and acceptance. So denial is feeling that death is not happening or did not happen, refusing to accept reality. Then you have anger, acting out, perhaps in ways that endanger others. Bargaining, trying to make a deal to postpone the inevitable. Depression, feeling and acting unusually silent, distant, and withdrawn. And then acceptance, unhappy but resigned to reality. How to remember these stages of grief are DABDA, D-A-B-D-A. Denial, anger, bargaining, depression, and acceptance. DABDA. Then we move on to bloodborne pathogens. These are disease-producing microorganisms in human body fluids. They can infect and cause disease in people who are exposed to blood or bodily fluids containing pathogens. Then we talk about body substance isolation, BSI. The Center for Disease Control and Prevention, the CDC, defines universal precautions as a set of procedures designed to prevent transmission of human immunodeficiency virus, HIV, hepatitis B virus, and other bloodborne pathogens to first aid or healthcare providers. The CDC standard instructs providers to assume that all blood and body fluids are infectious. So again, universal precautions are a set of procedures for bloodborne diseases. Body substance isolation, BSI, is the standard that requires using a form of infection control with all patients. BSI includes 2 basic behaviors. 1, PPE equipment, and 2, the practice of personal behaviors that reduce risk. Personal protective equipment and actions. PPE serves as a barrier against infection. Medical PPE includes eye protection, gloves, protective clothing such as gowns or coveralls, sleeves, or shoe covers, masks or shields, and biohazard bags. When washing your hands with soap and water, first wet them with water, apply soap, and rub your hands together vigorously for at least 20 seconds. If soap and water is not available, use an alcohol-based hand sanitizer with at least 60% alcohol. Your uniform, leather, or closed gloves and everyday footwear are not PPE. Then we have masks. There are 2 types of masks, filter masks and CPR masks. How to handle biohazard waste. The procedures you use to handle biomedical or biohazardous waste must comply with the Federal Occupational Safety and Health Administration, which is OSHA. There are requirements for identifying and segregating blood or waste materials saturated with body fluids. OSHA requires color-coded bags or containers for storing biomedical waste, such as red or yellow bags or containers with the International Biohazard symbol. Then we have to prevent MRSA, which is, interesting, methicillin-resistant Staphylococcus aureus. Long story short, MRSA is a type of bacteria that is highly contagious and resistant to certain antibodies. Staph infections, including MRSA, occur most frequently among people in hospitals, healthcare facilities, and detention facilities. So again, MRSA is a type of bacteria that is highly contagious. Maintaining equipment and supplies. Make sure after cleaning, disinfect using a hospital-grade disinfectant or chlorine bleach and water. The acceptable standard for dilution is 1 part chlorine bleach to 10 parts water and mixed just before using. Then we move on to infectious diseases and illnesses, bloodborne diseases. So we're going to start with Hep A, Hep B, Hep C, HIV, which includes AIDS, and then we'll move on to some other ones. So bloodborne diseases, we'll start with hepatitis A. This one is fecal and oral. Remember, A equals ATM, which means ass to mouth. So this is, think of it more fecal matter, right? So ass to mouth, hepatitis A is ATM, ass to mouth, fecal and oral. It is not a bloodborne disease. So hepatitis A is not bloodborne. It is highly infectious, but is preventable with BSI and appropriate PPE. So Hep A, ATM, ass to mouth, fecal is oral. Okay, fecal and oral. Then we move on to hepatitis B. This is bloodborne, and you get this by blood and needles, and you get flu-like symptoms. Outside of occupational settings, sexual contact, or sharing contaminated needles. So hepatitis B, think blood, bloodborne. Then we move on to hepatitis C. Hepatitis C stands for C is common contact. It's the most common, and this is bloodborne. This occurs from sharing needles or drug paraphernalia, needle sticks, contaminated sharps, or infected patient delivering their baby. Let's see if there's a B one here. Body fluids. I would say it seems like the biggest definition here is for hepatitis B. So if they're giving you some crazy example of some crazy one, and they don't say it's the most common, so it's not C, and they don't say that it's not bloodborne, it's not from fecal, and it's not A, then just assume it's B. That's kind of how I went for this test, and it worked. So that's how I'm going to go for it for the SOCE. Signs and symptoms of hepatitis. Signs and symptoms of hepatitis may include flu-like symptoms, fever, body aches, fatigue, loss of appetite, and weakness. Then we go to HIV. Another bloodborne virus that attacks the immune system is the human immunodeficiency virus, which causes acquired immune deficiency syndrome, which is AIDS. Transmission occurs primarily during sexual contact with an infected person, needles, unborn child, things like that. HIV has 3 stages: asymptomatic, symptomatic, and then AIDS. So that's pretty simple. Asymptomatic means you don't have symptoms, then you have symptomatic means you have symptoms, and then it goes to AIDS. Those are the 3 stages of hepatitis. Then we have airborne diseases. Well, actually, let me go to TB. Make sure TB stands for tuberculosis. A growing concern is the increase in the number of people with HIV who develop tuberculosis. So having HIV obviously weakens your immune system, and then when you have TB with a weak immune system, that allows it to grow, multiply rapidly, and then that could be what actually causes you to die, not the HIV. Then we have airborne diseases. Any infection spread from person to person through the air is an airborne infection. Breathing in microscopic pathogenic organisms causes airborne infections. The lungs provide accumulation sites for airborne infectious microorganisms that cause communicable diseases such as the common cold, chickenpox, both forms of measles, mumps, meningitis, influenza, and TB. Then we have COVID-19. The virus that causes COVID-19 is called SARS-CoV-2. Tuberculosis, if a TB patient does not respond to or comply with treatment, they can be civilly detained. So TB is pretty big. If they're not responding to or allowing you to comply with treatment, then you can civilly detain them so that they can get that treatment. However, when illness weakens the immune system, TB infection becomes TB disease. So you start with TB infection, and then when it weakens the immune system, it would turn into a TB disease. Tuberculosis usually transmits through family members, close friends, and people who work or live together, sharing close confined spaces over extended periods of time. So it's not really... So you could have someone in the back, as long as you have your windows down, you're fine. You kind of really only get this from being in a closed, confined area with a long time with people. That's why it would be your family or your coworkers, things like that. Know that hepatitis A is one serious illness transmitted by food. And the reason for that is because of fecal matter. So remember, A, ass to mouth, fecal matter, and it's orally. You get that orally. So when people are harvesting food or people are cleaning food, they could potentially have fecal matter on their hands from whether it's, wiping after going to the bathroom or things like that. That's where hepatitis A tends to come into play. Then we have sexually transmitted infections and diseases. Sexually transmitted diseases, STDs, or sexually transmitted infections, STIs, are among the most common infectious diseases in the United States today. So the most common are STDs or STIs. Of at least 20 identifiable sexually transmitted diseases and infections, 7 are most common: chlamydia, genital herpes, genital warts, gonorrhea, HIV infection and AIDS, syphilis, and hepatitis B. All are preventable if you take the proper precautions. All right, then we move on to Lesson 5, the human body. And damn, we still got a long way to go. I'm not even halfway yet. Woof! All right, Lesson 5, human body. We're going to start with the skeletal system. The skeletal system is the supporting framework for the body, giving it shape and protecting vital organs. The main components of the skeletal system are the skull, spinal column, chest, shoulder girdle, pelvis, lower extremities, and upper extremities. The skull houses and protects the brain, obviously. It also gives shape and function to the face. The hinged jawbone attached to the skull permits the jaw to move. The spinal column protects the spinal cord and is the primary support for the entire body. Spinal column is the primary support for the entire body. It consists of separate bones called vertebrae that stack one on top of each other and are held together by muscles. The shoulder girdle consists of the collarbone and the shoulder blades. The chest consists of the breastbone, which is the sternum, and the ribs. It protects the heart, lungs, liver, and spleen. The pelvis protects the reproductive organs and supports the organs in the lower abdominal cavity. The upper leg consists of the longest, strongest bone in the human body, which is the thigh bone, and this is the femur. So the strongest, longest bone in the body is the femur. The upper arm consists of one bone. The lower arm, like the lower leg, consists of two bones. So upper legs, you have one bone. Lower legs, two bones. Upper arm, one bone. Lower leg, two bones. Then we have the muscular system. The muscular system gives the body shape, protects internal organs, and provides body movement. So let's compare the skeletal versus muscular. Skeletal is a supporting framework for the body. It gives it shape and protects the organs, where the muscular system, obviously body shape as well, protects the organs as well, but it provides body movement. So if you see anything on body movement, that is the muscular system. If you don't see body movement, then it's a skeletal system. Muscles used for deliberate acts such as chewing, bending, lifting, and running are voluntary muscles. These are muscles attached to the skeleton and under the control of the nervous system and brain. The individual can contract and relax these muscles. Involuntary muscles, or also called smooth muscles, carry out many automatic body functions. They are in the walls of tube-like organs such as ducts, blood vessels, and the intestinal wall. A person does not normally control these muscles. Found only in the heart, the cardiac muscles work constantly to expand and contract the heart. Then we have the nervous system. The nervous system controls voluntary and involuntary body activity. It also supports higher mental functions such as thought and emotion. It also has two main systems. It has the central nervous system, which is located in the brain and in the spinal cord, and that would be your mainframe computer. And then you have the peripheral nervous system, which includes nerves that connect to the spinal cord and branch out to every other part of the body. So if you see anything about branching out, that's peripheral. And if you see anything about being located in the brain, that's the central nervous system. Then we have the respiratory system. The respiratory system delivers oxygen to and removes carbon dioxide from the blood. The blood can go without oxygen only for a few minutes. The body can go without oxygen only for a few minutes. So again, the respiratory system delivers oxygen to and removes carbon dioxide from the body. The circulatory system pumps blood throughout the body. It delivers oxygens and nutrients to and removes waste from the body's tissues. Basic parts of the circulatory system are the heart, veins, capillaries, arteries, and blood. Make sure you know that the heart consists of two sides, each having an upper and lower chamber. So that means two sides, four chambers. The right side pumps blood to the lungs, which pick up oxygen and returns oxygenated blood to the left side of the heart. So again, the right side pumps the blood to the lungs, and then that returns the oxygenated blood to the left side of the heart. The left side then delivers the oxygenated blood throughout the body and returns the blood to the right side. So the right side doesn't have any oxygen in it, and it gets pumped to the lungs. That blood gets pumped to the left side, which then goes to the entire body, and then it dumps back into the right to start all over again. Blood vessels are a system of tubes through which blood flows. The following major arteries determine blood flow and set the patient's pulse rate. So there are four of them. The carotid, which is the major artery in the neck, felt on either side of the neck. Then you have the femoral artery, that is a major artery in the thigh, felt in the groin area, and it's a femoral artery because it's right by your femur. The radial artery, this is a major artery in your lower arm, felt at the thumb side of the wrist. And then your brachial, which is a major artery in the upper arm, left on the inside of the upper arm. Vessel, so remember on a baby, you check the brachial artery, and then on a person that is unconscious, you check their neck, and a person that is conscious, you check their radial pulse. Vessels called veins carry blood back to the heart. Throughout the body, small vessels called capillaries connect arteries to veins. So they say what's our small vessels that connect arteries to veins, that's the capillaries. Remember, veins carry blood back to the heart, where arteries carry blood from the heart to the body. Blood is composed of the following elements: plasma, which is a clear straw-colored fluid. Red blood cells carry oxygen from the lungs to the body and bring carbon dioxide back to the lungs. White blood cells fight infection and destroy bacteria and other disease organisms, and platelets initiate the blood clotting process. The digestive system has two main functions: ingesting and digesting food and nutrients. This is mainly in the abdomen. This system This system's organs include the stomach, pancreas, liver, gallbladder, and small and large intestines. Then we have the endocrine system. The endocrine system regulates body systems by secreting hormones directly into the bloodstream from glands. These glands include thyroid, adrenals, ovaries, testes, and the pituitary glands. Again, endocrine regulates body systems by secreting hormones. So think of hormones, think of endocrine system. The endocrine system also maintains water balance and blood pressure. So 3 things. Secreting hormones, maintaining water balance, and maintaining your blood pressure. Then you have the the genitourinary system. We'll go with that. It is responsible for reproduction and waste removal. Okay, simple enough. Skin. Make sure you know that skin is the largest organ in your body. The skin serves as a protective covering for the inside of your body as well. Unit 2, Lesson 1, Scene Size Up, which starts with scene safety. Scene Size Up begins as soon as you become aware of a situation, whether you have been notified by radio or you come upon it in the course of your duty. The Size Up has 4 components: scene safety, mechanism of injury or nature of illness, the number of victims, and the need for more rescuers and special equipment. Mechanism of injury or nature of illness. Simply put, try to figure out what happened. That's what that means. A trauma patient is an injured person. A medical patient is a person who is ill. So again, trauma means injury, and medical patient means they're ill in some sort of fashion. All right, we'll move on to Unit 2, Lesson 2, Patient Assessment. So with assessment, you have 3 phases: initial, physical, and ongoing. Remember from CPR training that assessment begins with XABCs: examination, airway, breathing, and circulation. Make sure to consider the patient's response in determining the LOC, which is the level of consciousness. Then we have AVPU, which is alert, verbal, pain, and unresponsiveness, which would be your level of consciousness here. So identify responsiveness on 4 levels: alertness, verbal ability, pain response, and unresponsiveness. So again, AVPU, alert, verbal, pain response, and unresponsiveness. So alert, it determines if the patient is alert, what is your name, what day is it, things like that. Verbal, patient who responds verbally to your questions but appears disoriented, or maybe they only respond to loud noises or some sort of verbal stimuli. So if you yell at them and they respond, they're at verbal. Then we move to pain. A patient who does not respond to verbal stimuli but responds to pain stimuli is at a pain responsive level. So, for example, you can do a pinprick, pinch of their earlobe, or giving them a sternal rub. That would be at the pain responsiveness level. And then you have unresponsive. So a patient who responds to none of the stimuli listed above is unresponsive or unconscious. If you determine that the patient is unresponsive, follow the steps for CPR. So again, AVPU, they're alert, they're answering questions, they're talking to you. Verbal, they respond when you talk loud, you say something, or they're at the pain level. So when you walk up on somebody, you're going to say, "Hey, how are you doing?" Okay, they're not responding, they're not alert. Then you're going to make loud claps, loud noises, see if they move. Boom, they don't move. Then you're going to do some sort of pain. You're going to come up and pinch their earlobe, or you give them a sternal rub. Okay, they don't respond, they're not in pain. And then you come to the point where they're not responding to any of those, they're unresponsive, and then we would be looking for CPR potentially at this point. We have spinal immobilization. If your scene size up and initial assessment suggests spinal injury, manually stabilize the patient's head and neck with a cervical spine or C-spine, which is in the position you found them. So to do C-spine, you kneel at their head, you place your palms on either side of their head below the ears, hold the patient's head in the position you found it. If the patient is not breathing, use the jaw thrust to open the airway to initiate rescue breathing. Keep the patient in position until EMS completely immobilize the patient. So again, jaw thrust. Then you have jaw thrust with spinal immobilization. You're kneel at the patient's head, place one hand on each side of the patient's head with your thumbs resting on the cheekbones. Grasp the angles of the patient's lower jaw on both sides and press down with your thumbs as you lift the jaw. If the lips close, push the lower lip open with your thumb. Using a lifting motion to move the jaw forward with both hands, and this pulls the tongue away from the back of the throat. Keep the patient in position until EMS grab them. After you commit to stabilizing the head and neck, stay with the patient until EMS relieves you. So once you stabilize the neck, you cannot move. Then we move on to airway and breathing. Place the side of your face near the patient's mouth and nose to detect breathing. Watch the patient's chest and look for the rise and fall of the chest. Then we'll look at the lips, the fingernails, and the area around the mouth. Is it blue or purplish in color? Is the color of their skin changing to pale or gray color? These are signs of inadequate breathing. And we're going to go to the normal breathing rates. Normal breathing rate for an adult is 12 to 20 breaths per minute. A child is 15 to 30 breaths per minute, and an infant is 25 to 50 breaths per minute. So as you get younger, the breaths go higher. So again, adult 12 to 20, then it's 15 to 30, then it's 25 to 50. How I remember this is just automatically remember 12 to 20, and then for the next one, you minus 5 from the highest. So 5 minus 20 is 15, and then you go up 15. And then for the next one, you minus 5 again from 30 makes 25, and then it's 25 to 50. And it's always double. So the first one is 12 to 20. You just got to memorize that. Then you know the next one is definitely 15 because the last one was 20. And then you double 15 makes 30. Then 30 minus 5 is 25. And then you double 25 makes 50. So again, 12 to 20, 15 to 30, 25 to 50. Make sure to note the quality of breathing, which includes the rhythm and depth of breath. So with rhythm, you have regular and irregular. And then with your depth, you have normal, shallow, or deep. Or you have labored or painful breathing. Then we go to circulation. Assess the patient's circulation by pulse rate, also known as perfusion. So perfusion is the pulse rate. Skin color and skin temperature. Take a patient's pulse, place your fingers, not your thumb, on a pulse point. Again, like I mentioned earlier, on a conscious adult or child, check the radial pulse. On an unconscious adult or child, check the carotid pulse in the neck. On an infant, check the brachial pulse in the upper inside of your arm. Then we go to classifying pulse rate by its rate, rhythm, and force. So pulse rate for an adult is 60 to 100. Child is 100 to 120. And then infant is 120 to 160. So just remember that they all touch each other based on their highest one. So 60 to 100, then it goes 100 to 120, then 120 to 160. And then your practical number is that 100 to 120 range. Look for any uncontrolled bleeding and treat immediately before continuing with the assessment. So with rhythm, the interval between beats could be either regular or irregular, and then your force or strength of the pulse could either be bounding, which is strong, or weak, which is obviously weak. Skin color and condition. If the skin feels cool, the patient could be suffering from heat exhaustion, shock, or exposure to a cold environment. If the skin feels hot, the patient could have a fever or heat stroke. Change in body temperature can indicate poor circulation. A hot spot on the skin can indicate an affected area. Skin quality indicates possible circulation problems, and the patient's skin color and condition may be pale, red, or flush, blue, which can also be cyanosis, yellow, which is jaundice, moist, or dry. Make sure you know what anaphylaxis is. This is a severe allergic reaction in which air passages swell and restrict breathing. Then you have your physical or secondary assessment, which is DOTS, which is deformities, open injuries, tenderness, and swelling. Make sure to carefully work from head to toe, inspect and palpating. Remember, palpating is touching each body part before moving to the next. So physical and secondary assessment, which is DOTS, deformities, open injuries, tenderness, and swelling. Make sure to start at the head. Observe anything out of the ordinary, such as swelling, fluid loss from the ears or nose, discoloration around the eyes, which is called raccoon eyes, mouth injuries that may obstruct the airway, and discoloration behind the ears that may indicate brain trauma, which would be also called battle signs. So discoloration behind the ears is brain trauma, which is also called battle signs. You can also check for capillary refill by squeezing the patient's finger or toenail bed for 2 seconds. Then we assess for pulse, motor, and sensory functions, PMS. So we start with AVPU. And remember, with AVPU, we have alert, verbal, pain, and unresponsive. Then we move to... we start with XABCs. Okay, so initial assessment. XABCs, extenuation, airway, breathing, circulation. Then you determine the level of consciousness, which is AVPU, which is alert, verbal, pain, and unresponsive. Then you move to airway and breathing. So you're checking for the pulse. And then you're looking for physical or secondary assessment, which would be DOTS, deformities, open injuries, tenderness, and swelling. And then from there, you do PMS, which is assessing for pulse, motor, and sensory functions. With pulse, you assess for circulation by checking for distal circulation below the injury site. So if I have an injury on my right thigh, I'm going to check for my pulse down at maybe my right ankle. Or if I have an injury on the top of my right arm, I'm going to check my radial pulse by my wrist on my right lower arm. So the pulse by your foot is called your pedal pulse. So checking the distal circulation is important because if you're not feeling any sort of circulation below the injury site, then that means something's bleeding out. Then we move on to motor. Assess for motor function, movement of upper extremities. Ask the patient to move their fingers or squeeze your hand or move their toes. Then you have sensory. Assess for sensation before movement. Ask the patient if they have feeling where you touch. Then we move on to sample, which is the simple method may help you get information useful in determining causes of injury or illness. Sample stands for signs and symptoms. What can you see? What does the patient feel? Allergies. Does the patient have allergies? Medication. Is the patient taking any medication? When was the last dose? Then you move to past. What's past medical history? Last oral intake. When did the patient last eat or drink? And events. What events led to this incident? So again, that's sample. Signs and symptoms, allergies, medications, past medical problems, last oral intake, and events. And then you have your ongoing assessment. If the patient is stable, reassess every 10 to 15 minutes. If they're unstable, reassess every 5 minutes. So stable is 10 to 15. If they're not stable, it's 5 minutes. All right. Then we come to moving patients. Perform an emergency move when a patient is in immediate danger or the patient's location prevents providing care to them or another patient. Perform a non-emergency move such as a walking assist when the patient is not urgent. The recovery position helps maintain an open airway. Should the patient become nauseated or vomit, it may prevent positional asphyxia. So again, the recovery position. Positional asphyxia is a type of asphyxia that happens when the position of a person's body interferes with their ability to breathe. We move to emergency drags. You have the 1 or 2 person drag, the blanket drag, shoulder drag. Then we have the extremity lift or carry. And then you have the 2 person extremity lift. Then you have the SEAL Team 3 carry, which is the person goes underneath the shoulders, behind the head, and then the person in front carries between their legs. Then you have your log roll. Sorry. Let me back up. I said that wrong. The 2 person extremity lift is behind the shoulders and then the person between the legs. The SEAL Team 3 carry is you both get under 2 people, 1 under each shoulder, and you carry them while they drag behind. Then you have your log roll, which requires at least 3 people, and this is just rolling the body over to check for back injuries. Then you have your MCIs, your multiple casualty incidents. You may respond to some incidents that involve more than 1 victim or a multiple casualty incident. Make sure you know what triage is. This is the term given to sorting and classifying patients. Make sure you know what START is. START is simple triage and rapid treatment. This is the initial triage system based upon Florida Field Operations Guide. The START method of triage assesses a large number of victims rapidly, and personnel with limited medical training can use it effectively. So again, simple triage and rapid treatment. That's START. Make sure, so with simple triage, you have 1, use BSI and appropriate PPE. Locate, remove all walking wounded. If available, triage and tag remaining injured with triage colors. Step 4, you would classify patients according to START protocols. Red means immediate care, yellow, delayed care, green, minor care, ambulance, black is deceased, non-salvageable. Then you move on to circulation. Remember the mnemonic RPM, respiratory perfusion, which is, remember, perfusion is circulation, and mental status. 6, make independent decisions for each victim. Do not say, oh, there's too many greens, so I'm not going to make them green. If you encounter borderline decisions, always triage to the most urgent priority. So if you're stuck between green and yellow, tag them yellow. If you're stuck between yellow and red, tag them red. Direct the movement of patients to proper treatment areas. Step 9, provide appropriate medical treatment, XABCs. 10, the first assessment that produces a red tag stops further assessment of that patient. So if you determine, okay, shit, these guys are red, you don't need to continue assessing that person. As soon as they're red, they're red. The triage priority determined in the treatment phase should be the priority used for transport. And 12, if you identify a victim in the initial triage phase is red and transport is available, transport them right away. Okay, so here's how it works. Here's the chart for steps for START. Are they walking? First thing you do is RPM, respirations, perfusion, and mental status. So are they walking wounded? If they're yes, green tag. If they're no, then you move on to R, which is respirations. So open the airway and assess for respirations. If the respirations is less than 30, then you'd move on to perfusion, but we're not going to get there yet. So we're going to start with R, which is respirations. Open airway and assess respirations. If there's no respirations, they're black. So if there's no breathing, they're black. Remember, this is quick start. So this is quick start triage. So if they're not breathing, you black tag. We don't have time for CPR and all this other stuff. Then you move to, if there is a need to maintain airway or if respiratory rate is greater than 30, you give them a red tag. So if you need to hold their mouth open, if you need to keep them breathing, that would be red tag. But if the respirations are less than 30, you move on to perfusion. With perfusion, you're checking for a radial pulse or capillary refill. If no radial pulse or it's delayed greater than 2 seconds, then you give them a red tag. If they do have the radial pulse or the capillary refill, you move on to M, which is mental status. Patient follows simple commands. No, red tag. Yes, they do follow commands, then you give them a yellow tag. Florida implements the Incident Command System, ICS, for multiple agency response in times of disaster. Now we're moving on to shock, and unfortunately we've reached just about halfway. So I'm going to go ahead and pause this before I get into shock. Alright, this is a continuation, part 2 of Chapter 2, First Aid High Liability book, and we're going to jump right here into shock. Shock is the failure of the heart and blood vessels, aka the circulatory system, to maintain enough oxygen-rich blood flowing to the vital organs of the body. Shock occurs to some degree with every illness or injury. Shock can be life-threatening. Signs and symptoms of shock may include anxiety, restlessness, and fainting, nausea and vomiting, excessive thirst, eyes that are vacant and dull, lackluster with large dilated pupils, shallow, rapid, and irregular breathing, pale, cool, or moist, clammy skin, weak, rapid, or absent pulse. Treatment for shock. To treat a patient for shock, you have 6 steps. 1, maintain an open airway. Remember your CPR training. Use the head tilt, chin lift method to open the patient's airway. If you suspect spinal or neck injuries, use the jaw thrust method. Prevent further blood loss by controlled breathing. Elevate the lower extremities. Position the patient on their back and elevate the lower extremities 6 to 12 inches. If you suspect the patient has serious head, neck, spinal, or pelvic injuries, do not elevate the lower extremities. Keep the patient warm. Cover the patient with suitable material to maintain body heat. 5, perform ongoing assessment of the patient for life-threatening conditions. Maintain XABCs. 6, be prepared to perform CPR and use an AED if available. Then we're going to move on to Unit 3, Lesson 2, Bleeding and Soft Tissue Injuries. We start with a contusion, which is bruising. This is a closed injury that is discolored and painful at the injury site. Bruising is the obvious discoloration, black and blue, of the soft tissue at the injury site. So if they talk about black and blue, then that's bruising. But if they talk about just an injury, discolored, painful at the injury site, that's a contusion. Then we move on to hematoma, which is a swelling. The hematoma is a closed injury that appears to have a discolored lump. Swelling is a soft tissue raised when blood or other bloody fluids pool beneath the skin at the injury site. So the question comes up, it's going to be hematoma, not swelling, but make sure you know what swelling is. Open soft tissue injuries. So we have 6 of them here. You have an abrasion. These are open injuries. An abrasion, open wound caused by scraping, shearing away, or rubbing the outermost skin layer. Then you have an amputation, the gross removal of an appendage. An avulsion, injury characterized by a flap of torn or cut skin that may not be completely loose from the body. Evisceration, an open wound where the organs protrude out. A laceration, open wound that varies in depth and width. And a puncture wound, result of driving a sharp or blunt pointed object into soft tissue. So a puncture wound could be like a gunshot. How to remember these? Remember them by AAA LEP. AAA LEP. So abrasion, amputation, avulsion, and then you have evisceration, laceration, and puncture wound. Bleeding control is the first important thing you need to do on the scene. There are 3 types of bleeding. Arterial bleeding, which is bright red blood spurting from the wound, indicating a severed or damaged artery. Venous bleeding, which is dark red blood flowing steadily from a wound, indicating a severed or damaged vein. And then capillary bleeding, dark red blood oozes slowly from a wound, indicating damaged capillaries. Make sure to control bleeding. You apply direct pressure until bleeding stops. If the first layer of dressing does not control the bleeding, do not remove it. Just apply additional layers. With avulsions, remember an avulsion is a flap or torn skin. You're going to remove any debris from the wound, align the flap to its normal position, and secure the wound in place with a clean dressing. Then we have a tourniquet. T stands with a tourniquet. You're supposed to do this last, and this is the rule of the book. This is not real life tourniquet. You're probably going to use it first, but for the book, you're using it last. A tourniquet is a device that restricts blood flow to an extremity, such as an arm or leg. Use a tourniquet when the amount of blood loss endangers the victim's life and other methods of controlling the bleeding have failed. A rough-edged amputation is the most common use of a tourniquet. A rough-edged amputation. Make sure when applying dressing and bandages, dressings are coverings applied directly to the wound, where bandages are coverings that hold the dressing in place. So the dressing, you put it right on the wound, and then use a bandage to hold that dressing in place. Puncture wounds. Puncture wounds are usually the result of an object, blunt or sharp, penetrating the skin's soft tissue. Impaled object. An impaled object is an object that punctures the soft tissue and stays in place. Okay. Gunshot wounds. Gunshot wounds can cause serious injury by fragmenting, penetrating, vibrating, and damaging internal organs. They can cause cavitation, which is the space left by tissue that is destroyed. So cavitation is just the space that the bullet leaves behind when it's just destroying the tissue. Here's another thing here. Make sure to apply 3 minutes of pressure after applying combat gauze. Let's see. Then we have types of gunshot wounds here. So let me do a couple here. Obviously, with a 12-gauge shotgun, you're gonna have a whole bunch of pellets coming in. Obviously, the bigger the gauge, the more damage it does. Know that a bullet, when it enters the body, it sends sonic shock waves. You obviously have fragments. What else is here? Detached muscles. Yeah, just know what cavitation is. That's the space left behind as the tissue is destroyed. Then we move on to spinal, head, and neck injuries. We're going to start with spinal injuries. If the patient has suffered a significant trauma, complains of neck or back pain, cannot move fingers or toes, or feels numbness or tingling, stabilize the head and neck to prevent movement and further damage. Then we move to head, face, and scalp wounds. Head and neck injuries are among the most serious emergencies. So head and neck are the most serious. Then we move infant head trauma and brain injury. A traumatic brain injury, TBI, is an injury to the head and brain. If an infant or child younger than 6 years of age, it is usually the result of violent shaking or blunt impact. So under 6 years of age, you're probably going to have blunt impact causing a TBI, and that would be considered child abuse. Let's talk about hypoxia here. That's a lack of oxygen. Ischemia, a lack of blood circulation, and interesting. Encephalopathy, which is brain damage. A bruise, burn, or mouth injury in an infant younger than 7 months who is not mobile is called a sentinel injury. It is a relatively minor abusive injury that cannot be reasonably explained. Sentinel injuries can precede severe physical abuse, such as abusive head trauma. So basically, a sentinel injury means they didn't do it themselves, someone did it to them. So it would be a bruise, burn, or mouth injury in an infant younger than 7 months who is not mobile. So obviously, if they're not moving, they can injure themselves. Eye trauma. Types of eye injuries can be eyelid injuries, chemical burns, objects impaled in the eye, and an extruded eyeball. Make sure to, when you're cleaning the patient that has chemical burn in their eyes, position the patient's head so that the unaffected eye is above the affected eye, and make sure to flush it out for 20 minutes with water. Neck injuries. For deep lacerations in the neck, apply an occlusive, airtight dressing. So when you have deep lacerations, you're going to apply an airtight dressing, which is an occlusive dressing. Airtight, occlusive. Then we're going to move on to chest injuries. A closed chest injury results from blunt trauma to the chest area. It damages internal organs and can cause internal bleeding. A flail chest is a type of closed chest injury. It occurs when 2 or more adjacent ribs are fractured in 2 or more places and become free-floating. So basically, flail chest is when your ribs are free-floating in your chest. Obviously, a closed chest injury, that's when there's blunt trauma, but there's no open injury. Then you have an open chest injury, and this occurs when penetration, such as a knife stab, opens the chest area. A sucking chest injury is a type of open chest injury, such as a gunshot wound in which air and blood escape into the area surrounding the lungs, creating a change in the pressure in the chest cavity. And with these, this is when you would apply a sucking chest injury. For a sucking chest injury, you're going to apply an occlusive airtight dressing to that injury. For an abdominal evisceration is an open wound where the organs protrude from the abdominal cavity. Maintaining an open airway is your first priority, and make sure you cover the wound with a moist dressing. And you're just going to kind of hold it there until you're not going to push it in, you're not going to pull it out. You're just going to hold it there until someone relieves you, basically. All right. Extremity injuries. So we're going to start with the medical term for a broken bone is a fracture. So again, fracture, medical term for a broken bone. An open fracture, the skin at the injury site is broken and the bone may protrude through the skin. So an open fracture, that's when the bone's coming out, that's when the skin's broken. Then you have a closed fracture, the skin at the injury site remains intact. So pretty simple, open, it's open, closed, the skin's not broken. Then we move to mechanism of injury. There are several types of force. Break a bone. Looks like the book misspelled this here. So there's several types of force that can break a bone. You have direct force. This causes injury at the point of impact. Force may be delivered from a blow to the head with a baseball bat or a driver's chest hits the steering wheel. So that's direct force, injury right at the point of the impact. Then you have indirect force, which causes injury past the point of impact. The break may occur when a falling person extends the arm to break the fall and breaks their elbow. So if a person falls, the point of impact is at their hand/wrist, but what actually breaks would be your elbow. Where with direct force, if you hit the ground with your hand and wrist would break. That would be direct. Where indirect is you're landing on your hand, but your shoulder or your elbow would break at that point. Then you have twisting force. This causes injury when one part of a limb remains stationary while the other twists. The result can be a spiral fracture, a bone break often caused by sports injury or physical abuse. So a sports injury, physical abuse is definitely twisting force, and that would be a spiral fracture, because it's spinning as it breaks. Okay, remember again that DOTS is deformities, open wounds, and tenderness and swelling. Dislocation, sprains, and strains. A dislocation occurs when the end of a bone comes out of its socket at the joint. That's dislocation. Treatment for dislocation, sprains, strains, and fractured bones is the same. Do not try to put the dislocated bone back into place because major blood vessels and nerves can line near the joint. Further injury may occur if you do this improperly. Treat sprains and strains like fractured bones. So just kind of hold them in place, don't move them, try to take the pressure off of them, things like that. Remember, we have splint, swings, and slings, and swaths. We know that a splint is when you kind of put like a hard piece of wood or something like that and you tie things around it to keep it from moving. And then you have, obviously, the sling. Then you have the swath, which would, the swath takes pressure off the arm and holds it in place, where the sling, let me go back a little bit. The sling is obviously what holds the swath and the splint in place. So the splint, you're going to put under the broken arm, wrap stuff around it to hold it. Then you're going to have the swath, which holds the splint and everything else in place. And then the sling just simply takes your pressure off of your arm there. Then we move to amputation. There are two types of amputations, complete and incomplete. Pretty simple as that. Obviously, complete means the arm is laying 5 feet away from the body. Incomplete means it's still attached, whether by skin, muscles, veins, things like that. Then we move to burns. These are classified by depth. Burn injuries are classified by depth. You have first degree, second degree, and third degree. First degree is called a superficial burn, and this damages the first layer of the skin, which becomes red and feels very painful. Then you have partial thickness, which is second degree burns. This damages the first 2 layers of the skin. You'll see blistering, and it'll be very painful. Do not puncture the blisters, as the open wound is vulnerable to infection. Try to keep the blisters intact. Then you have full thickness, which is third degree burns. This damages all layers of skin and affects muscles and nerves. The skin looks waxy, white, and charred. So a good way to remember superficial, partial, and full thickness is SPF. So think of sunblock, SPF, superficial, partial, and full. Superficial is just top layer, partial thickness is 2 layers of skin, full thickness is all the way through. Superficial just becomes red, partial thickness, it blisters, and full thickness, you get waxy, white, or charred. Then we have burn locations. If the patient's face is burned, they may also have suffered an inhalation burn, which is a burn to any part of the airway, and swelling may obstruct the airway, obviously. The major long-term concern about burns is preventing infections. So that's the major concern with burns are infections. All right, anatomy of childbirth. Unit 4, Lesson 1. We start with the uterus, an organ that holds the developing fetus. The cervix, it's the neck of the uterus, contains a mucus plug. A placenta is a dish-shaped inner lining of the uterus, provides nourishment and oxygen to the developing fetus. Birth canal, the passage the fetus is pushed through during delivery. The umbilical cord connecting the fetus and the patient, transports nourishment to the fetus. Amniotic sac is the bag of fluids surrounding the fetus. You have your stages of labor. The final stage of pregnancy, labor, begins the birthing process. So the final phase of pregnancy is labor, and that begins the birthing process. So labor begins the birthing process. Labor consists of contractions of the uterine wall that force the fetus and placenta out of the patient's body. Normal labor occurs in 3 stages. So once you hit labor, then there are 3 stages of labor. You have dilation, which is the preparation. The first stage begins with the first contraction and continues until the fetus enters the birthing canal. Dilation is the opening of the cervix. During this stage, the amniotic sac may rupture. As a result, fluid gushes from the vagina. When this occurs, the patients may say, "My water broke." To remember the stages of labor, remember it as DEP. So think deputy, DEP, DEP, dilation, expulsion, and placental delivery. So that's the dilation, that's the opening of the cervix, and that's when the fetus enters the birthing canal. And then you have expulsion, which is delivery of the baby. In the second stage, the fetus moves through the birthing canal and is born. Soon the fetus's head crowns or becomes visible as it emerges from the vagina. And then the shoulders and the rest of the body should follow. Then you have your placental delivery. This is the third stage. The placenta separates from the uterine wall and moves through the birthing canal for delivery. This stage usually occurs within 30 minutes of the baby's delivery. So again, DEP, dilation, which is preparation, then expulsion, you deliver the baby, and then the placenta. All right, in a normal delivery, you do not need to cut the umbilical cord. However, clamp or tie it, keep the newborn warm, and wait until EMS personnel arrive. Complications during childbirth. Prolapsed umbilical cord. In some deliveries, the umbilical cord comes out of the vagina before the baby's birth. The fetus head compresses the cord against the birthing canal. This cuts off the fetus' supply of oxygen into blood. If you notice the prolapsed cord, arrange for rapid transport and instruct the expectant patient to assume a knee-chest position. So if you see a prolapsed cord, you're just doing rapid transport and you're putting them in knee-chest position. You're not cutting that. You're not removing it, things like that. Then you could have an umbilical cord around the neck. The umbilical cord wraps around the baby's neck and you cannot remove the cord. Encourage the patient to continue breathing and stop pushing. If necessary, place clamps or ties about 3 inches apart on the cord and carefully cut between them. Remove the cord from the neck and follow the steps of a normal delivery. So if the umbilical cord is around the neck, you are going to cut the umbilical cord and take it away from the neck and then go about the delivery. If you have a breech birth occurs when the fetus's feet or buttocks present down the birthing canal first. If this occurs, arrange for quick transport and position and prepare the patient for delivery. Support the fetus's legs and body as they deliver. The head will follow. Never try to pull the baby from the vagina by the legs or trunk. If the head does not deliver within 3 minutes, keep the baby's airway open by forming a V with the fingers of your gloved hand. Turn your palm towards the baby's face. Form an airway by pushing the baby's face away from the birthing canal until the head delivers. So with a breech birth, you're going to obviously work on transporting, but delivery has to keep going from here. So that's where the legs or the butt is coming in first. You're going to allow for the normal delivery. You're not make sure to support the body. You're not going to pull it because the head and neck are very sensitive. And if the head cannot get out within 3 minutes, you are going to put your fingers in there and make a breathing pathway for the baby. You can have a limb presentation. A normal delivery is not possible if the fetus leg or arm appears first. A physician needs to deliver this baby. So limb presentation, you're not doing nothing. Excessive bleeding after delivery. Arrange for rapid transport. If there is like a tear in the vagina or anus, treat as you would an open wound. So apply direct pressure, and do not throw away blood-soaked pads. Stillborn delivery, a baby who dies long before delivery generally has an unpleasant odor and exhibits no signs of life. Make sure to give special considerations to the parent. Do not try to resuscitate him. Carefully wrap it in a blanket, and just wait for medical care at that point. Then you have multiple births. Deliver multiple babies in the same manner as single babies. Simple enough. The second baby is usually born within 45 minutes, and just repeat the process. Then we have asthma, heart attack, and stroke. Asthma results from airway passage narrowing. That's about it right there. To treat a patient experiencing severe asthma, BSI, PPE, position the patient for comfort, try to get them an inhaler and make sure they use it. You're not allowed to give somebody an inhaler. You just give it to them and tell them to use it or put their hands on it and have them push down on it. Then we move to a stroke. A stroke is damage to part of the brain due to the rupture or blockage of a blood vessel. So again, stroke is damage to the brain. Time is of the essence with transport. Symptoms of a stroke include numbness, paralysis of extremities, typically on one side, confusion or dizziness, difficulty speaking or slurred speech, difficulty with vision, headache, seizures, diminished consciousness, difficulty breathing, facial drooping, and so on and so forth. So again, a stroke is damage to the brain. Then we have a heart attack. This is caused by oxygen deprivation to part of the heart, typically from a blocked blood vessel. Symptoms are difficulty breathing, chest pain, nausea, vomiting, dizziness, irregular pulse. So if it's difficulty breathing, that's big on heart attacks. Chest pain, that's big on heart attacks. Back pain, shoulder pain, pressure in the center of the chest, that's all heart attacks. Where with stroke, remember, that's numbness or paralysis on one side, confusion, dizziness, seizures. Then we move on to diabetes and seizures. Diabetes is a disease that causes the body to not produce or properly use insulin. Insulin is a hormone needed to convert sugar, starches, and other food into energy needed for daily life. There are two types of diabetes. Type 1 is insulin-dependent, juvenile diabetes, and type 2, diabetes that can be controlled by diet or medication. So think of type 1 as the worst. 1 is the worst. That one you're kind of born into. You just have that. Type 2, that's the second worst, or rather second best. That's controlled by diet and medication. So if you have a good diet and you take medicine, you're fine. Signs and symptoms of a diabetic emergency can include intoxicated appearance, staggering, slurred speech, things like that. Altered mental state, including dizziness, irritability, drowsiness, confusion. Sweet, fruity, or acetone-smelling breath that you might mistake for alcohol. Irregular breathing, rapid or weak pulse, flush, dry, warm or moist, sweaty or cool skin, and seizures. Then we move on to seizures. Seizure symptoms range from a blank stare into space or random shaking to twitching extremities or whole body muscle contractions. The condition causes mild to severe convulsions of the body or a body part, and seizures are rarely life-threatening unless they continue indefinitely or 2 or more consecutive seizures occur without a period of responsiveness in between. All right, Unit 4, Lesson 4, that is heat and cold-related injuries. Heat and cold emergencies may result in body injury and can ultimately cause death. Okay, so heat and cold emergencies may result in body injury and can ultimately cause death. So heat and cold, they can cause death. Okay, make sure you know that the body stays cool by sweating, which is perspiration, and breathing, respiration. So if the question is, how does your body stay cool? You're sweating and you're breathing. That's how you stay cool. The body transfers heat without contact, radiation. The body also transfers heat with contact, conduction. So if we're talking about transferring heat without contact, that's radiation. Think of like a light radiating onto you, the sun radiating onto you, where the body also transfers heat with contact, which is conduction. So you touch something, think of conducting, right? Electricity, it's touching you. That's how you transfer heat. The body maintains heat by constricting blood vessels near its surface. Your hair stands erect, which would be goosebumps, helping to keep warm air near the skin. The body produces heat by shivering. So again, let's go back again. So the body stays cool by sweating and breathing, which is perspiration and respiration. The body maintains heat by constricting blood vessels near the surface and getting goosebumps, and the body produces heat by shivering. So if you're shivering, that's you're making heat. If you're breathing and sweating, you're trying to cool down. Now we move on to heat-related emergencies. Make sure to get cool very quickly. Let's start here. Hyperthermia occurs when the body cannot recover from this fluid loss. So think hyper as heat and hypo as cold. So hypo, cold, and hyper, think heat. H-E, hyper. Hypothermia occurs when the body cannot recover from this fluid loss. So let me start over again. So heat-related emergencies can occur from loss of fluids and salts through heavy sweating. Hypothermia occurs when the body cannot recover from this fluid loss. So basically, when you're super hot, you sweat so much that you're losing all these important fluids and salts, and hypothermia occurs when you can't recover from that. Hypothermia has 3 stages: heat cramps, heat exhaustion, and heat stroke. So again, you're getting cramps, then you're exhausted, and then it's stroke. So heat stroke can be life-threatening. Signs and symptoms of heat-related emergencies can include cramps, strong rapid pulse, headaches, appetite loss, vomiting, seizures, warm, sweaty skin, moist, cool skin. So in the heat cramp stage, you get warm, sweaty skin. In the heat exhaustion stage, it's moist and cool skin. And then in the heat stroke stage, it's hot and dry skin. To treat a patient with heat cramps or heat exhaustion, fan the body, encourage an alert patient to drink, perform an ongoing assessment, prepare for CPR. So when you're hot, you're allowed to get cold very quickly. So if somebody's really hot, you throw them in a cooler, you get them cold as quick as possible. Where if someone is cold, you have to gradually warm them up. You can't just throw them in a hot room. You can't just start heating them up because then their body you'll screw up their bodies. So, again, if you're hot, you get them cold as quick as possible. If they're cold, you start warming them up slowly. So now we're going to start with cold-related emergencies. Exposure to cold causes two types of emergencies. Hypothermia, an excessive cooling of the body's core temperature, and frostbite, a localized injury from overexposure to cold. So remember, frostbite, think of like your fingers breaking off. That's a localized injury from cold, where hypothermia is an excessive cooling of the body's core temperature. Symptoms would be shivering, numbness, changes in pulse rate, sluggish pupils, bluish skin, cardiac arrest. Never considered a hypothermic patient deceased until the patient is warmed in an appropriate medical facility. So again, they could just be so cold and their heart rate's so slow that you think they're dead when they're not really dead. To treat a patient with hypothermia, remove them from the cold environment, remove the wet clothing, warm the body gradually by dry blankets or clothing, and encourage a fully conscious patient to drink hot, non-alcoholic, non-caffeinated liquids. With frostbite, you're going to treat that. You're going to move, obviously, the clothing, cover it with a dressing or padding, put their extremities or whatever it is in lukewarm room temperature water, not hot water. That's about it with that one. Then we're going to move on to abdominal pain, poisoning, and drug overdose. Only about 4 or 5 more pages here. Almost there. Lesson 5, abdominal pain, poisoning, and drug overdose. Abdominal pain. Separated from the chest cavity by the diaphragm, the abdominal cavity contains several body systems. The abdomen is a large part of the body, and abdominal pain is a common complaint. Sometimes you can get pain right over the affected organ, or you could have an infected organ on your right side and feel pain on your left side, so it can kind of move around. As the first officer on the scene, do not spend time trying to determine the cause of the pain. Instead, recognize that the patient has an abdominal problem, complete a thorough patient assessment, and wait for EMS. So if someone has abdominal pain, you're not going to sit there and waste all this time trying to figure out where it is, what it is, things like that. You're just going to contact EMS and be on standby. Then we have poisoning. There are 4 ways to get poisoned. Poisoned by ingestion, inhalation, injection, or absorption. So poisoning can cause allergic reaction, injury, or death if introduced to the body. Poisons can be solids, liquids, or gases. So poisoning by ingestion occurs when poison enters the body through the mouth. So if you're ingesting it, it's going through your mouth. Poisoning by inhalation occurs when the poison enters the body through the mouth or nose, but like in a breathing format. Where ingestion is like you're eating or drinking something. Where inhalation is you're breathing in through your mouth or nose. Poisoning by injection. This occurs when poison enters the body through a small opening in the skin. Poisoning by absorption occurs when poison enters the body through contact with the surface of the skin. Poisoning from insect stings. Africanized bees can present a life-threatening situation to someone who is not necessarily allergic to bee stings because of the number of times the bee can sting someone. So Africanized bees, those can be life-threatening because basically you'll die from 10,000 bee bites, and just the shock alone is what's going to kill you. If someone does have some sort of, if there's a stinger in the skin, how you would remove that is you scrape the stinger away from the skin with the edge of a plastic card held at an angle. Do not use tweezers to remove the stinger. You may push it further into the skin and inject more poison. So you're going to use a card and you're going to scrape it off from an angle. Then we'll move to anaphylactic shock. Anaphylactic shock or anaphylaxis results from insect bites or stings, medications, pollen, foods, chemicals, or any substance that triggers an allergic reaction. Anaphylactic shock is a life-threatening emergency. We move on to poisoning from snake bites. Snake venom contains some of the most complex poisons known. They can affect the central nervous system, heart, kidneys, and blood. Depending on the type of snake venom is a digestive, enzyme, or neurotoxin. Signs and symptoms: 1 or 2 puncture wounds, nausea, vomiting, drowsiness, slurred speech. A lot of kind of the same symptoms here for all of these things. When you're treating snake bites, do not apply ice to the bite site. Do not cut the wound. Do not apply a tourniquet. Do not apply alcohol. Do not use your mouth to suck the venom. Let's see. Poisoning from marine life stings. Signs of these could be swelling and redness on the surface of the skin. Do not rub the wound. Use vinegar. Things like that. Then we move on to a drug overdose. A drug overdose is an emergency that involves poisoning by legal or illegal drugs. Opioid overdose. Fentanyl is a synthetic opioid that mimics morphine but is up to 100 times more potent than morphine and up to 50 times more potent than heroin. So again, fentanyl is 100 times more potent than 100 times more potent than morphine and 50 times more potent than heroin. Pharmaceutical fentanyl was designed for pain management. Florida is seeing a sharp rise in deaths causing by fentanyl. And then you have carfentanil is 100 times more potent than fentanyl. Remember, the name for Narcan is naloxone. That is the official name for Narcan. Narcan is just the brand name. So again, that's naloxone. All right, then we have fentanyl exposure. We have low risk of exposure, moderate risk of exposure, and high risk of exposure. So low risk would be it's not airborne, it's low quantity, and there's no contamination. Examples would be a small amount, pills or capsules. What you should do, put on gloves, wear long sleeves, and use a mask and eye protection. If there's a moderate risk, it's potential for airborne, moderate quantity, and it's possible contamination. There's potential for the powder to become airborne. Make sure to cover your torso and arms, double glove, put on a mask and eye protection. So you're covering your torso and your arms and double glove. Then if you have high risk, it is airborne, and there's a high quantity and severe contamination. Loose powder in the air, widespread contamination. It's in a tight space, difficult to remove. Evacuate immediately, call a hazmat team, have on-site decontamination ready if possible, and have medical personnel on standby. Then we move on to administering naloxone. If you're administering naloxone, minimize your exposure to fentanyl by using PPE. 1. Administer a dose of naloxone every 2 to 3 minutes until the patient is breathing on their own for at least 15 minutes or until EMS arrives. If the signs and symptoms return, give another dose after 2 or 3 minutes. Multiple doses of naloxone may be required to stabilize the patient. Continually monitor the patient's medical condition. So every 2 to 3 minutes, you can give more doses. Then we move on to excited delirium. Excited delirium is a state of extreme mental and physiological excitement characterized by exceptional agitation and hyperactivity, overheating, excessive tearing of the eyes, hostility, superhuman strength, aggressiveness, acute paranoia, and endurance without apparent fatigue. Unbelievable strength, hyperthermia, remember hyper is hot, ability to offer resistance, sweating, nudity, bizarre behavior, aggression, paranoia, foaming at the mouth, whole bunch of stuff here. And that actually concludes Chapter 2, First Aid.